that we have Professor Aung, who is the director of the Singapore Eye Research Institute.
Thank you very much. So I'd like to first say that I don't work on gene therapy in glaucoma. I do work on genetics of glaucoma, but not on gene therapy. But Tanuj gave me a very difficult topic to talk about, and it also says something very new. I have no disclosures. So when we talk about gene therapy, we're talking about correction of genetic defects either by gene replacement or gene modulation, and hopefully to emulate symptoms by delivery of this therapeutic target. So in ideal therapy, of course, the expression occurs in the target cells in the desired amount in a time-dependent manner. It's non-pathogenic, non-immunogenic, non-toxic, and hopefully with a single administration, you get long-term expression. Now, today I'll give an overview of the talk in terms of why the eye is a very good organ for gene therapy and how successful we are in the field of gene therapy, particularly for retinal dystrophies and Leber's congenital amaurosis, for example, and give an overview of glaucoma genetics and how gene therapy could be used for glaucoma, and including some currently on trials. So let's start with the eye. Why is the eye a good target organ for gene therapy? I think, as you know, it's a highly compartmentalized, and we have easy delivery for the vectors that can be delivered into the eye within microsurgical techniques. And because it's compartmentalized, you don't have much systemic side effects. The tissues are small with small volumes required. And the eye has got immune privileges. The immune response is usually not too great. We have optical transparency, and we can measure things easily. We can quantify the visual function, both psychophysically as electrophysiology as well. And also we have the contralateral eye as a control. So these are very good reasons why the eye is good for gene therapy. And there's lots of new virus vectors now that can be used for eye gene therapy, and also animal models. And of course, for retinal dystrophies, we have the subretinal space, which is very close to the target for the gene therapy, which is the photoreceptors or RPE, and you can have very concentrated delivery with immune privileges. So these are very good advantages. So let's talk about gene therapy for retinal dystrophies. This is a very big field, a very hot field. And as you know, retinal dystrophy is a common blinding disease, affects about 1 in 2,000 people. And these people, many of them have progressive visual loss and blindness. And until the advent of gene therapy, many people have no definite treatment, and these people just go progressively blind, some of them in young adulthood, and then permanent blindness. So if you could correct it with gene therapy, this would be an ideal disease. And there are two kinds of retinal dystrophies, as you know, recessive ones, in which case there's loss of function of a gene, for which you should aim for gene replacement. And then dominant diseases where there's some mutant gene transcripts in which you need to either aim for suppression or replacement strategies. So the first world FDA-approved gene therapy, of course, is RP65 for Leber's congenital amaurosis, and I'll talk about this in a while. And there's several others on clinical trials, including autosomal recessive RP, Usher syndrome, Stargardt's, and choroidemia, and further others under preclinical studies. So let's talk about Leber's congenital amaurosis first. And this is a very severe blinding disease, and many of them are caused by RP65, this gene called RP65 mutations. And this RP65 is essential for the production of 11-cis-retinol, which is the immediate precursor to 11-cis-retinal. Okay? And there's a good animal model, is a dog model, a Briard dog, which is similar to human RP65. They also get this same kind of a blindness. They are normal at birth, and then they start losing the ELG signal at 5 months. Then they get both day and night blindness. And there are some homozygous mutation, RP65, which also has similar human analogous mutations. So this Briard dog was used as a gene therapy trial. And this is a dog, Lancelot, they delivered a subretinal delivery of the AAV vector with the RP65 gene, and it has substantial improvement in visual function. And several follow-up studies were conducted, and here you can see up to 3 to 4 years visual improvement after one delivery. So this was an amazing result in this dog model. And the dog continues to still see well since 2000. So that was delivered in 2000, and now almost 20 years later, the dog still has good vision. and apparently more than 50 dogs have been treated in a similar way. So this was the proof of concept on animal model of how gene therapy works. And so this led to the RSP65 Leber's congenital amaurosis trials in 2008. And there was, in 2008, there was several publications of the effect of the RP65 gene therapy. And one was from the Moorfields group, one from Jean Bennett in Philadelphia, and another group from the US. So these were successful gene therapy trials. So this led to the creation of a company called Spark Therapeutics, and this is led by Jean Bennett's group. And this was the first FDA-approved drug for a one-time gene therapy for patients with certain RP65 mutations in LCA. So this was big news, and as you know, it is now approved, and in some countries in the US as well as in Europe, the insurance may pay for this therapy. And Novartis has since licensed this Luxturna, and so now it's a relationship between Luxturna and Spark. And it's very expensive, unfortunately. It's like a few $100,000 for one therapy. But you know, it's almost the vision of the patient improves drastically. So from previous almost blindness, they can get navigational vision, and even in some people, they'll be able to have some good quality of life. So, and this is a major landmark for gene therapy for ophthalmology. And there are others which are under other companies, as Nightstar, which is working on choroidemia, and Avaxis, Coithera, etc. So these are all gene therapy companies which are already doing trials in humans. There's also, of course, gene therapy for Leber's hereditary optic neuropathy, and this is another exciting field which possibly could lead to improvement in vision. So let's talk about glaucoma. Can you do gene therapy for glaucoma? Now, as you know, we have patients with glaucoma who have progression of blindness in spite of excellent IOP control, even after trabeculectomy, and these are the patients who progressively get worse, and these are the ones where, you know, whatever we do, they keep going down and they get blindness. So this is one potential group, of course, whether we could potentially, you know, target the RGC. Perhaps you can also target the trabecular meshwork of the optic nerve head. So these are potential target areas for gene therapy for glaucoma. So let's look at glaucoma genes. Now, as you know, there's a certain proportion of glaucoma is inherited as a Mendelian or dominant fashion. So for example, myocilin is one of the major Mendelian genes for glaucoma, and this probably accounts for about 5 to 10% of POAG, and these are pedigrees. And there are also other genes like optineurin, which is more like a normal tension glaucoma, WDR36, ASB10. So these are dominant forms of glaucoma which we have in some of our patients. We also have congenital glaucoma like CYP1, B1, LTB2, which are, as you know, are recessive diseases. But the vast majority of our glaucoma are complex, which means that they have genetic risk factors only. They don't have like a one major mutation or one major gene that's responsible for the glaucoma. So in most of our patients that we have glaucoma, they have so-called genetic risk factors. And for that, you need to use a GWAS approach or genome-wide association study to find genetic risk factors. And several GWASs have been done for open-angle glaucoma. You can see here more than 20 genes have been identified for genetic risk factors with small effect sizes of between 1.1 and 1.2. But what's more important is that from the GWAS, you can see that some of the pathways that have been identified, and these include mitochondrial pathways, lipid pathways, etc. And so people are now looking, can some of these be targets for gene therapy? So let me give you an overview now of some of these potential targets. So for example, for the Mendelian group, the myocilin, there's work now on doing a CRISPR gene editing for some of these mutations, which can improve protein aggregation. And this is work that's done in Iowa and others. Then for the GWAS hits, there are several targets here. One of them is TK, and which are related to Schlemm's canal development. So this could be a target to improve the Schlemm's canal function, and others for lipid metabolism, and others for mitochondrial dysfunction. So these are potential therapies which are targets for gene therapy, but these are, of course, a long way off. So let's go, what's closer to currently is the a target of the retinal ganglion cells. So this is something which is already going to clinical trials. And basically for retinal ganglion cells, we have three approaches. You can try stem cells or gene therapies to try to regenerate or improve their function. And the group led by Keith Martin in Australia, formerly from Cambridge, is targeting RGC survival. And they are using a target of BDNF or brain-derived neurotrophic factor, which they found to be a target, and this that by upregulating this gene, it protects against RGC loss and is neuroprotective. And this is done in several animal models. So I'll share with you the next few slides data from Keith Martin. And basically, he started off by doing a rat glaucoma model, and they found that using AAV with the brain-derived neurotrophic factor, they had improved rescue of RGCs after 4 weeks of experimental glaucoma. And then they did several models, an optic crush model again, showing again increase in RGC survival. And then they did another model, a trabecular laser model, where they induced high pressures by lasering the trabecular meshwork of the rat. And again, they found that applying this BDNF gene therapy, it was strongly neuroprotective in this model, with a good RGC axon preservation in a long term. And it even led to increased optic nerve connectivity to the brain. So this was quite amazing results from this target of BDNF. And also they showed also, not only in terms of IOP and connectivity and RGC loss, also improvement of ERG function as well. So this is some evidence of how BDNF could be a target for gene therapy. And now their company called Acutera is starting a clinical trial in humans to test out gene therapy of BDNF through an intravitreal application. And this will then upregulate the BDNF in the RGCs of the retina. So this is something which is already going to start, and they're targeting people who have progressive glaucoma in spite of good intraocular pressure. These are people who are progressing in spite of good intraocular pressure control, so something else is going on in these people. Finally, a couple of slides on whether we could target the trabecular meshwork, and this is work from Paul Kaufman's group from Wisconsin. And there are several genes, I put it gene X here because I think it's proprietary, to try to target the meshwork to upregulate upflow of trabecular meshwork. And my colleague Shamira Pereira here, he's working at Paul Kaufman in Singapore, so they're working on primate studies. So they're delivering this vector, or again AAV vector, through little catheters, like 125 microns, into the Schlemm's canal, like a canaloplasty procedure. And this is some of the work that they shared with me. And you can see here they're using a GFP antibody, which is a coloring antibody, to show the principle of how you can upregulate in the meshwork itself. You can see the red staining here to show that it can be delivered into the canal and the Schlemm's canal and trabecular meshwork area via the canaloplasty. And this is work that Shamira actually cannulates the monkeys. So, you know, he's very expert on cannulating monkeys, so I'm sure it's no problem cannulating humans. Yeah. So I think in summary, we are on the cusp of new gene therapy for glaucoma. As I told you earlier, it's already established in the retinal dystrophies. We have an FDA-approved drug for Leber's congenital amaurosis. And there are different approaches, as I mentioned. Some of them could be targeting the RGC, some would be targeting the trabecular meshwork, others could be targeting gene targets such as GWAS hits as well as mycilin. And of course, we need to think about how gene therapy will fit relative to other treatment strategies, not like retinal dystrophies where it's all blind and we have to rescue the one with one gene therapy. Here, as you know, for glaucoma, we have multiple approaches to treating glaucoma, and which targets are most promising and who are the ones who will need this gene therapy. So there are still lots of questions to be answered. I'd like to acknowledge my colleagues, Chan Choi Man, Keith Martin, and of course, Paul Kaufman and Shamira Pereira for help with some of the slides. Thank you for your attention.
So it was a really fantastic talk, and I was just curious about the BDNF. That would theoretically work with all glaucoma patients where maybe a specific gene we don't really have for most of our glaucoma patients. Is that the big attraction for the BDNF?
Okay, So the BDNF is to improve RG survival. So I suppose it could be used for all forms of glaucoma. But obviously, you know, we have other treatments like IOP lowering and others. So, you know, you probably need to use it in a subgroup of them who are rapidly progressing in spite of good IOP levels, or people who are in, you know, you don't find a way of arresting their progression. So this is probably the group. I don't think you will be using it for everybody, you know, because probably the cost will be too high and the other risks. But definitely in that subgroup of patients who are rapidly progressing with no other options available for us, in spite of our maximum efforts in IOP lowering, this would probably be a good group. Yeah.
I was also curious about the BDNF. If you were looking for cells that were sick, or you know, patients who had low pressure already and they continue to progress, do you think it would need to be paired with maybe some adaptive optics or some sort of way of figuring out why these patients are continuing to progress?
I think, you know, we don't know. Some people, we have patients who progress regardless of whatever we do, and we don't know what's the reasons, what's happening in them. You know, is it sometimes, like, you know, I worked on a family with optinurian mutations. They got pressures of 10 to 12, but all rapidly progressed to extensive visual field loss and blindness. You know, so some of them are really genetic. Others we don't know, whether it's a mixture of blood flow, biomechanics. You know, we don't know. Yeah.
Great. One last question. You know, it's common for our patients to ask us about whether they should be tested for glaucoma with genetic testing. Do you have any comments about that, and is it useful, and who should we recommend?
Okay. So currently, I think if you have a strong pedigree, yes, you should test them. With a very strong family history, you should test them. And there are several genes which have Mendelian inheritance. Apparently, for the GWAS, I think there's no need to test at the moment because it's not going to improve at the moment. So there's no test available, and the predictive value is very limited. Although the recent UK biobank study showed that if you combine all the GWAS hits currently, you can pick up to 70% of glaucomas, POAG. So, you know, this could be something in the future. As you work out more of the genetic mechanism, you can predict. But I think, you know, at the moment, about 70% of glaucomas can be detected. Yeah.
Thank you. Any questions from the crowd?